I like to think data as sort of the red blood cells of an enterprise. They bring oxygen everywhere, yet if they're by themselves, they mean absolutely nothing.
So the best data is the one that is available to you. If everybody is building data in their own silos, you have no access to that data, and it is basically defunct at that point.
And all of a sudden, you start proliferating enrollment data all over the place as you built out different processes out of necessity, but you didn't have this master plan built out when you designed your data model. So we're now looking at our enrollment data model and saying, we've dispersed a lot of data. We could probably centralize it, but we're going to have to wrap our heads around every place this data is used and figure out a strategy that allows everybody to do their business process the way they need to do it.
Being able to unlock the data so that way our innovators, even within VA, there's a lot of good work across many of the offices across VHA to actually take that data to help improve value-based care models, to provide point of care decision points based off of existing data models.
Good morning. My name is Michael Hoffman, and I'm the president of Government CIO Media and Research. Welcome to our virtual event this morning on data sharing. Government CIO Media and Research is the online destination for thought leadership and research focused on the transformation of government IT. Our experienced team collects the best practices and research regarding the advancing technology and management landscape. I want to thank everyone who's tuned into the live stream for us. We have an excellent lineup of speakers, including agencies such as the Department of Veterans Affairs and the Defense Health Agency, as well as LexisNexis Risk Solutions. We've all felt the effects of COVID-19 in our personal and professional lives. But what about the effects on already complex government processes and services, like healthcare? We'll hear from these leaders from these groups and how they're working internally across agencies, the private sector to use data and data analytics to respond to the current health. I want to thank today's sponsors, Dell Technologies, Slack, and especially LexisNexis Solutions for underwriting this event and making these important conversations possible today. Without our sponsors, we wouldn't be able to bring our audience valuable content like this virtual event. Before we get started, I wanted to remind audience members that you can submit questions for our speakers in the comment box you see below the video player on your screen, and our moderators will choose some to ask during the conversations this morning. We want you to be a part of the event today and take part, so we're really looking forward to the feedback. So without further ado, I'd like to welcome our first panel to the virtual stage. We're going to kick off with our managing editor, Amy, who will be moderating the event. Amy, take it away.
Hi, everyone. Nice to have you this morning. We have a fabulous panel today with Dr. Paul Tibbets, Executive Director of the Office of Technical Integration at VA, Alan Constantian, Senior Advisor at VA, Andrew McClenahan with LexisNexis Risk Solutions. So I'm looking forward to getting right into talking about data sharing, especially in response to the current pandemic. Interoperability and easy communication between and among agencies have been pivotal during the pandemic response. This is especially so as many move to mass telework. It's why we're all meeting like this. Veterans Affairs having the largest integrated healthcare system in the country, of course, with frontline workers directly responding to the crisis and beyond, it's activated its fourth mission and in support of the nation during this national emergency. So I wanted to open up with an introductory question to all the panelists. We can start with Paul Tibbets. Big picture, Paul, give for us the biggest impact that you have seen to your operations as a result of the pandemic.
Sure, let me get off mute here. Absolutely. So just by way of overview, and I'm sure we'll have a little bit of time to go into some more details, but obviously I think the real story here is kind of twofold. One, telecommunications, remote connectivity, everything you could imagine necessary to support a telework approach to getting work done. So all of the communications implications and whatnot of that. Second would be sort of what we call ops normal. What are those things we've been able to accomplish despite the new approach to work, working at a distance, telework, et cetera, and necessity for our clinical staff to focus on COVID-19 pandemic and taking care of patients. So those would be the two big areas that I would say where we've seen this COVID-19 impact. And, we'll go more into that as we go through the discussion, I'm sure, this morning.
Great. And Alan, what about from your point of view?
So I think that the biggest impacts that we've had, of course, have been challenging the infrastructure to rise to the occasion, both in terms of telehealth visits, but also in terms of employee, many employees being online. Of course, there are almost 400,000 government employees in VA. Those in the hospitals are mostly still in the hospitals, but there's a larger percentage who are out, like Dr. Tibbets and I, working full time on telehealth. But the story about the expansion of telehealth visits in this emergency, where our veterans are hesitant to come to hospitals for the risk of, maybe encountering a virus, is really a great story to tell that maybe we'll have a chance to tell later on.
And Andy, with you being the industry representative on this panel, what have you been seeing on your end?
Well, I think firstly, I think it would be fair to say that the government was not ready for a national pandemic. And I think that to effectively and efficiently deliver those services and enact the provisions of the CARES Act, I don't think it's caught everybody unprepared. So it's required the private industry sector to be nimble enough and capable of implementing customized solutions to meet the government's need in this, and especially with the very urgent needs to distribute the benefits and the stimulus funds. And I think that it's required us to make sure that we have industry subject matter experts to work hand in hand on the fly with the government technology and policy staff, because there was really no clear direction. Go do it, figure out how to do it, and that has really impacted us. And I think that providing support for all the different states and all of the different entities that are out there providing support for their call centers has been, I think, a challenge for the industry across the board.
So we have heard how important data sharing is to the pandemic across government. Even before the pandemic, we've heard how data is gold. Paul, you just mentioned how, from an IT perspective, the agency has responded into two different buckets, being ops as normal or ops in response directly to the pandemic. So what do some of those data sharing efforts look like at VA right now?
From a lot of aspects to your question, but from a data sharing perspective, I would say, again, our telecommunications capabilities would be some of the most impressive, at least they certainly are to me. For example, in early May of this year, we VA had about nearly 105,000 VA Video Connect visits. That's telehealth visits, 105,000 compared to 10,000 in March. So a tenfold increase. We've had 850% increase in telehealth visits from January to April. We've actually set up 110 local locations with tele-ICU service. We have sent out 4 what are called vet text messages to 8 million veterans. And then we have a text application, Annie, which gets over, from a usage perspective, over 6,000 messages a day. So these have all been, and that represents a threefold increase in usage since the end of March, and nearly a tenfold increase in provider prescribed protocols on precautions and quarantining, et cetera. So I would say, from my perspective, those are, I would say, fairly dramatic impact, which we have been able to respond to Andy's comment earlier, I would say industry partnership here is extremely important to us. Supply chains are extremely important. Without our industry partners, of course, we would not have been able to accomplish these expansions in many instances requiring increased equipment installation somewhere or other. That equipment had to be bought, had to be shipped, had to be installed, et cetera, et cetera. And certainly our industry partners were vital to the success of those efforts.
Andy, do you have anything to say in response to that, considering industry?
Well, I mean, I think Dr. Tibbets brings up some great points, and I think that the emphasis on the data sharing, on having near real-time data, so it's both timely and relevant for any analysis or artificial intelligence risk scoring, and particularly in any COVID biosurveillance process, has been pretty critical.
Alan, you actually just recently rejoined the VA because of the pandemic. So what brought you back to the agency, and what are you kind of tackling right now?
So I'm tackling a couple of things, Amy. So what brought me back, something that Sloan Gibson and Bob McDonald, our previous deputy and secretary of Veterans Affairs, talked about, which is mount up and ride to the sound of the guns. So when the opportunity came I was working in the private sector part-time because I did want to retire, although my plans got changed by COVID. Can't travel much in the COVID world. But when the national emergency struck and Dr. Tibbets and our principal deputy, Dom Cusat, said, hey, there's an opportunity to come back and work in the national emergency, it was a no-brainer. I've been a public servant for over 30 years. It's a national emergency. Where else am I going to be? I know the VA's people, process, and technologies. Right now, I'm working on something really interesting, I think, thanks to Dr. Tibbets, and just was able to jump in just as the plane was taking off and analyzing our veteran data integration and federation tool. It's an adaptation of health systems products. Or intrasystems products, rather. And what's really exciting is that we've connected 132 different Vista instances in anticipation of the rollout of the Cerner initiative. So we have the data all in one place and capturing it in near real time. And we've been able to use that as a springboard for a national surveillance tool that, with our industry partners, we were able, and working with the Veterans Health Administration clinicians, we were able to put up so we can see really critical data, both at the local level where it's actioned, but also at the national oversight level. And it wouldn't have happened without having this technology in place and without having done the planning for the infrastructure that was necessary in order to support all of this. That went back a couple of years in the making.
Speaking of Cerner, where does that stand right now, Paul?
Well, that would be an example of ops normal, and I think I can summarize in general the work, and then let me talk about what I know about schedule at the moment. But from the work perspective, if you could imagine any work that could be conducted remotely in a telework metaphor, that work has continued. So software development, cybersecurity, documentation, authority to operate, authority to connect, et cetera, has all continued pretty much unabated. Really, the only impact of COVID on that is in a few instances where some healthcare professional, subject matter expert, for example, might have been necessary for testing. That testing, either we had to find a replacement for that person or that testing had to be delayed, but because those subject matter experts were busy taking care of patients at the hospital. So, but there's been minimal COVID impact on that kind of interface work. Where the impact is seen most is site level activities. So where servers had to be installed or on-site configuration had to happen because we did not allow travel, either of VA employees or contractors for that matter. That on-site work couldn't happen and therefore had to be displaced forward into the future. We're getting ready to open that up right now, probably this month. But so that was the impact. And even the local IT staff, we couldn't use them for that kind of installation work because they too were busy actually supporting the clinicians who were taking care of patients. So the on-site staff was really busy because with COVID patients as well, even though they weren't direct patient, delivering direct patient care. So that's been the major impact. And so schedule, I told you I'd come back to. We're in the middle of a lot of discussions about, so therefore, when will the new go-live dates really be? We haven't quite settled on that yet. VHA, of course, Veterans Health Administration leadership is looking very closely at the evolution of the pandemic itself, where, there's a lot of unknowns involved in there that we're all wrestling with to figure out when we can get back to those on-site activities that are related to install and go live. But it looks like that might be beginning to open up. Anyway, those discussions are very active right now. We certainly have briefed Congress on that, and they understand the uncertainties with respect to how the pandemic is going to evolve and the impact of that on the local staff. So I'd say those are the two areas, on-site activities and the work that can get done by some distance telework metaphor.
Now, going into a little bit on the IT infrastructure side that you alluded to earlier, describe some of those and how that has helped the VA, quickly pivot to enabling its fourth mission and responding to the pandemic, both within the VA itself and in the front line.
Well, so let me come to the IT staff last in that question you just asked me. So I'll back up to the Veterans Health Administration. For example, we, OINT, had probably 15 or so representatives on the daily calls with all of the VISN and veteran VA Medical Center directors. So we were directly there listening for what the IT impact of something or other might be. I director and VISN 20 had some latency, blah, 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 whatever it was. We were there taking notes and, literally as soon as that call was over, we were all on our call saying, okay, what's the latency problem? What caused that? Go fix it, et cetera, et cetera. So in something, again, approaching very near real time, we were understanding what the requirements were as they were rolling literally out of the mouths of the VISN directors saying, I had this problem or that problem, or whether it was bed management system or biosurveillance or whatever it happened to be, supply chain issues and data in that regard. Sort of real-time feedback loop there between the Veterans Health Administration leaders and us and OINT to address whatever their immediate concerns were. Then, in order to do the work, we have had of course, a dramatic increase also in OINT telework. Essentially, everyone except the people who are at a hospital, everyone in OINT is on telework. So it's if you're not other than the hospital support staff itself, we're pretty much at 100% telework. So in April, we had nearly 138,000 connections over VPN or CAG. And even with that, we have yet to exceed capacity at all. From February, we had 120,000 connections, now 240,000 over Rescue VPN. Our Rescue VPN, our ultimate target is for 500,000 sessions. We think we'll be there by the end of the summer. And CAG, likewise, usage went from 16,000 in February to 20,000 today. And our ultimate capacity there for the Citrix Access Gateway, we would believe our target is around 130,000. So the dramatic increase, again, in those telecommunication capabilities, which have allowed us to do over telework, the ops normal stuff that I just described to you earlier.
And Alan, being, I guess, a boomerang, how do you see that from your point of view?
Well, I think it's really exciting, but both from supporting the workforce as well as being able to support our veterans, as Dr. Tibbets alluded to with the VA Video Connect work. But I also think it's really exciting the way that we've been able to do some things really quickly to enable our efforts, especially in this COVID emergency, with like the national surveillance tool that was built in, really in weeks, that shows, who's ordering COVID labs, where are they being ordered, how long are the labs taking, what's the test status of patients, how many patients do we have, where, in terms of equipment, where do we have isolation and negative pressure rooms? Because these are being built on the fly in sort of mothballed spaces where they didn't exist before. ICUs are appearing where they hadn't. Whole hospitals are appearing where they haven't. We took over a shuttered facility that was shuttered in 2018 in North Texas in Garland, and made it operational in just a few weeks when it takes usually a few months. The other thing in the national surveillance tool, ventilators have been in the news. We're counting ventilators through this national surveillance process. We're counting PPE equipment at specific locations. And the other thing that was really exciting that we've been able to do with data is because we had a good handle on the equipment, the beds, the negative pressure rooms, the ICU space, we've been able to open to non-VA patients compassionate care community beds where there's overflow in the community and where VA has capacity without putting at risk our first obligation to our veterans. This is our fourth mission. And then we've also, in situations where veterans are in private sector nursing homes, we've been able to bring them in for critical care where they might have gone to the community, but there are people, veterans are our first charge, and we've been able to say, hey, we have the capacity, they're veterans, they're qualified, want to take care of them. So it's been really exciting coming in and seeing us be able to build on the building blocks that we had and scale up very quickly to meet the immediate needs that the COVID emergency has had. So all of my hopes when Dr. Tibbets and Dom said, we could use you, and okay, I'll run to the sound of the guns, have been fulfilled in this past month, where I've seen so much having taken place. And now, I'm putting my shoulder to the wheel to try to continue in that effort.
So we actually have a audience question similar to what we've been discussing. Can you talk through some of the challenges that come with having two different electronic health record platforms when doing some of the surveillance activities with the tool?
So go ahead, Dr. Tibbets.
No, I didn't know who the question was for, but no, go ahead, Alan. You go first. That's fine.
Well, let's see. So I'm not sure if the two platforms that are being referred to are the Cerner electronic health record platform and the Vista platform. So let me answer it as if that were the question. But if not, they can ask a follow-up question. But one of the really exciting things of this VDIF initiative, the Veteran Data Integration and Federation, is that not only did it link the 132 Vista instances, but it also has a gateway and connection into the Cerner databases. So as we move forward and move into Spokane and the Puget Sound healthcare system, that data from Cerner will sort of swim in the same data lake as all of the Vista information for the locations that are still in Vista. So we should be able to do the reports really seamlessly because all of the data is in this one VDIF lake that can be drawn on and in near real time. So I'm not really worried about that. And all those interfaces are already built. So we're just, waiting for some of the remaining on-site work and training to be done for the go live. But we're set to go to this two-platform situation for electronic health records that will be on for a number of years, as you know.
I guess I would add data migration and data syndication, which I'll explain in a minute, are part of the activities necessary to harmonize two electronic health record environments. So we're loading data migration is the loading. So we're loading a one-time load of all veteran data, every veteran that has been seen in the VA, irrespective of location, anywhere, into the Cerner system, Healthy Intent. We're using a technology we call it the VX130, but actually the core of that technology is the same InterSystems commercial off-the-shelf product that's the core of VDIF. It's the same tool. So that loading is going on every veteran, and it's about 20 or so, 22 data domains as we count them. And those are the main domains that are necessary for a physician to deliver healthcare. So every veteran on the major domains related to healthcare. We're also starting data syndication, which is bringing the data back once a veteran is seen or something happens or some healthcare process is executed on the veteran, whatever it happens to be. That data is going to come back from the Cerner product into the VA computing environment, into our corporate data warehouse for us to do the consolidated reports for the department, and management activities, given that the length of the Cerner rollout. So we're going to have that data harmonization, that data syndication work, that data harmonization work is activities and happen for the duration of the Cerner rollout. So I'd say those are the approaches we have taken. And then I think, I don't know if Alan mentioned the community care partners. In the meantime, we have gone live already, actually in production, and I should have mentioned this earlier with respect to Ops Normal, the Joint Health Information Exchange. We did, despite telework and COVID and you name it, we planned to go live on April the 18th. We did so, and we're successfully exchanging information with 200 plus healthcare partners. A healthcare partner could be a 5-doctor organization, or it could be the whole entire state of Georgia. Or Kaiser Permanente, that's a partner. So we brought on about 200 or so of those partners already. And by the end of the summer, we will have brought on, I think it's in the neighborhood of another 200 or so, but it's all the healthcare entities that are connected to the Commonwealth network. We'll be connecting that to Joint Health Information Exchange by the end of the summer.
And we'll definitely hear more about that joint health information exchange on the next panel with DHA. But there's certainly lots of things going on in response to the pandemic. Andy, from your point of view, where are you seeing the most opportunities or advancements for government to harness data, maybe now or in the future after the pandemic?
That's a great question. But just to add on to what Paul and Alan were saying, because they're doing some really great stuff, especially with their electronic health records. That those data lakes and the integrations with the hundreds of community partners that are providing health services out there, particularly with the expansion of telehealth to Medicaid and Medicare. Means that it's going to be critical for patient linking and patient identity linking so that all the records are lining up with the right people, and you can't rely on social security numbers to do that. So that comprehensive identity data and linking capabilities is really critical. As to your question about the what we're seeing, I guess, for opportunities for advancement, I think the partnering with industry to access those robust public records data to advance the healthcare services, especially with providing assistance to veterans and protecting their safety, identity verification tools to authenticate customers, clients, patients in every program area, especially with the expansion and the access of patients to being able to get to their records. That has to be timed with the improvements to some, quite frankly, some antiquated technologies that exist across government spectrum in just about every program area. And I think that's been part of the challenge with COVID. I believe that we'll also see, I think, a call for federal programs to have a single point of entry for whether it's identity or for administering programs that are run by some of the states, so that there is a quick and nimble response and to reduce the duplication. But I think the greatest impact is going to occur when the agencies are sharing data with each other and their smart analytics linking tools, not just for the sake of having data come together. It's what are you going to do with it now? And a crawl, walks, run strategy may need to be that time cycle shortened for immediate responses and use of data, particularly in response to COVID. And I think that this pandemic really demonstrated the need to be nimble and to accelerate that movement from to preventive and proactive use of linked disparate data sets. I think we need to be prepared for effective transparency into the usage and the ROI for data analytics, not just for cost avoidance integrity efforts, but for lost ROI opportunities, and especially with the particular limited capital resources that government is trying to deal with, and then add the COVID crisis. And so that may mean that the government needs to continue to update and reevaluate policies, procedures, rules that have been previously interpreted that constrain data sharing. So that's, I think, some of the greatest opportunities that they have, not just to harness data, but what they're doing with it and how.
And Paul and Alan, how do you see some of the efforts that you are doing now in regards to especially telehealth and more mobile capabilities? How are you seeing those having lasting impact in the future?
Well, and Alan, given his background, may have a deeper insight into this than I, but he has had a long career also at Health and Human Services before coming to the VA. But so I'm sort of speculating here on my part, but I don't know that healthcare is going to be all that different than any other sector. I think people are going to discover what is capable in a remote metaphor, telework kind of metaphor, and as a result of this, and we won't return to the same normal that we were before. I don't know, to personalize it, I mean, I just talked to my wife the other day. I said, I start my workday here at 7:30. I ended at around 5 o'clock at work here at home, and it would be 2 more hours if I had to go to the office every day. So I'm just wondering, how would I get all this work done if I have to go back to the office every day? I mean, so on and on and on. I mean, and whether that's also buying, consumer items now online, et cetera. So if I go back many years in my 20 years in my career, I can also tell you when we were very much in the Navy, very much at the beginning of telemedicine, the most popular app that got telemedicine launched in the Navy was mental health, and particularly with support out to sailors aboard ship or otherwise forward deployed. And I think that that's going to continue to grow, I think, in importance, in my sense, when people realize that it's feasible and provides benefit. So I think it's going to set a new normal. It would be my sense of it.
Depending how you look at it, a new normal or a new abnormal. So we are right out of time, but thank you guys so much for your perspective, and especially giving us a glimpse into what's going on at VA, maybe some things that we're looking out for in the future. And and Andy, thank you as well for that industry perspective. So I will hand it off to our next panel, moderated by Jason Windsor.
Thank you, Amy.
Okay.
And good day to everyone. I'd like to welcome Bill Tinston and Pat Flanders to our data sharing forum to discuss some of the ways data sharing has been modified under COVID-19 in our current scenario and get some of the feedback from them. I'd like to start with a question kind of for both of you that basically goes around with the mass move telework nationwide. Some of that was just discussed in the previous panel. How has DHA transitioned its systems to support that move? Bill, if we could start with you.
Well, why don't we start with Pat on that one? Because Pat has really made the fundamental core changes and worked with the Defense Information Systems Agency to enable it. Then I'll jump in and I'll talk about what I've seen, how we're able to work effectively.
Okay, thank you. So, what we did with telework to accommodate all the people that had to work from home really was amazing. And I'd like to thank DISA for their awesome support. That's Vice Admiral Nancy Norton, Major General Yee, Rory Kinney, my engineers, Tom Hines, our infrastructure and operations folks led by Dave Bowen, our Global Service Center led by Colonel Freddie Jenkins, which is basically our 300-person, 24-hour-day help desk, and the over 1,000 people at Naval Information Warfare Center and their contractor staffs. Just great stuff. So one of the first things we did, if you think about it, when you take your notebook computer home and you want to VPN back into our network, but really the destination you're trying to go to is a commercial website. Well, that is a huge performance hit because you're basically coming into the DoD network, then turning around to go out to the commercial destination. The response then goes back into the DoD network and then back out again through the VPN to the person at home. And so working with DISA, we were able to implement something called split tunneling. This was Tom Hines' idea, his genius. And basically using the new cloud-based internet isolation capability that DISA had been piloting with us, when you now are external to the network and your destination address is commercial, it routes it directly there. So you don't have that in and out and 4 times hit. That was an immediate 50 to 70% reduction in network demand. And normally to do something like that, to roll out something like the cloud-based internet infrastructure, that had taken 6 months to a year, and we did it in 2 weeks. And so we broke a little glass. So the first 3 days of it was a little exciting, but we got it done. And then on top of that, we rolled out, working with DISA and the DoD CIO, the Microsoft Teams implementation. We call that the commercial virtual remote environment, or CVR. And again, this is something that normally would have taken, 6 months to a year. We did it in 4 weeks, and all with quick ad hoc training and the support of over 130 hospital CIOs operating on 5 different networks, with systems configured differently. Our customers really liked it, and that's kind of catalyzed our move to implement Office 365 overall. I think you're going to see a big push to that here real shortly.
Pat, so based on the telehealth, or the telework that we had just discussed, obviously that turns and can transition into telehealth and virtual health tech as well. So what changes and priorities occurred in response to the current coronavirus pandemic in regards to telehealth and virtual health tech in your office at the DHA?
Right. So the first thing, because of the nature of the virus, being able to see video along with voice for a visit, really wasn't a thing, right? You didn't need to see a rash to really help people with COVID, that kind of stuff. And so largely we used the telephone, and it was a lot quicker. That said, the hospitals never closed. They were open the whole time. Babies continue to be born, people continue to have heart attacks, and behavioral health people needed to do telehealth. And because for them, being able to see the patient, their expressions, their body language, those are important things. So the first thing that happened was the president relaxed HIPAA standards. And that allowed us to use commercial peer-to-peer voice and video services. Now, the issue there is, our government network is specifically designed to prevent that kind of stuff and to open it up so that we could use those commercial services through the networks. And remember, we also do things like disable cameras, disable microphones. And with everybody teleworking, we had to figure out a way to do that remotely as best we could. So when we went to pick the commercial products, we knew we couldn't choose all of them. There's hundreds of them. And so what we did is we picked Google Duo, Skype, and FaceTime. And we picked those three because, you have to have an account to use them. And 97% of America has an account with one or more of those products. So that was huge. The other thing we did is Cisco CMS is a product that allows voice and video, and it works quite well. We've been using that in Europe and in Korea and a few places in the United States. So we took that capability, took the servers we had because they were already accredited, and it was easier just to scale them up than go buy something new. So we did that. And now we've got the capacity to do 16,000 visits a day overall. And so then on top of that, we had to modify all of the scheduling software in our legacy systems so that you could actually make an appointment that was a virtual appointment with the appropriate links and all that. So that took some work to do those kinds of things. So those were the big muscle movements. And, the other big eureka that came out of this, because we spent a lot of time talking about this, was that virtual health, and I'm going to steal some of Bill's thunder here because he's not on, is really an extension of the workflows in the electronic health record. And so in the new MHS Genesis EHR, it really made sense for Mr. Tinston and his folks building MHS Genesis to kind of be in charge of that. And so Mr. Tinston, coming out of this, is going to be the material developer for the virtual health component moving forward. I think that's a really smart thing to do. And I'm not going to talk more about it in case he can get back on, and because I know he's got some more things he wants to say about that.
I think Bill may be on audio now. Can you hear us, Bill?
I hear you. I don't know where we left this. So tell me where you want me to pin if you hear me.
Pat was just talking about some of the telehealth capabilities out at DIMS.
Right. And I told him that Google Duo, Skype, and FaceTime, and what we did with CMS, right, and that there was kind of been out of this, we discovered that, virtual health is really an extension of the EHR, and you are now going to be in charge of that.
Right.
And I thought you would have more to say about it.
Yeah, and we've been working with the VA very closely, and Dr. Evans over at the VA, who led the implementation of much of the virtual health capability at the VA, and they're several years ahead of us at this, and they're integrating it into our joint Millennium solution, or MHS Genesis, as we call it. So we're looking, and Lieutenant General Place asked me on the Genesis side to look at extending the workflows that we're delivering across the military health system with MHS Genesis, extending those workflows, improving the access to care through virtual technologies to both the legacy, so we're getting ahead on the legacy side, and creating integration into the MHS Genesis solution that we have out there, and doing that rapidly. So we're looking at solutions, really adopting the VA solution and integrating with the VA in both tele-ICU and virtual video visits. We're looking at getting something beginning to deliver this month in that space, which is a big change from, I think, where we were. I mean, Pat and team have just done amazing things, getting things in place immediately to support the immediate COVID response. What has happened on the Genesis side is there's a recognition that while this was in our schedule and scope, it was way down the road, and it needs to be done now, and our future wave deliveries need to include this set of capabilities. So we're doing that now.
Perfect. Thank you. On that same transition point, with the recent joint venture and go live with the Joint Health Information Exchange with the VA, how has that helped some of the clinicians that you've seen on the front lines of the virus?
Isn't that Joint Health Information Exchange an awesome thing that we've accomplished there? So it's
sir.
something that the VA and the DoD did together. I mean, with partners, there's lots of partners involved in that. But we took two individual efforts where we were integrating individually with health information exchanges. We made it a common health information exchange, and that's not just a technical solution. This was a programmatic solution. We changed our interaction with these health information exchanges. We have one set of agreements up front. When you agree, you only have to do the legal agreements once. You're in. Both departments take advantage of it immediately. It's integrated into MHS Genesis and the Millennium solution, so that providers, physicians can review the stuff from the records and incorporate it into the military health record. And at the same time, that new capability, the new connections that are available to everyone through the joint longitudinal viewer in the legacy environment and the new environment. And just to tie in, that's a huge joint thing that we've done with the VA. I was talking to Admiral Schofield yesterday from the Coast Guard about how we're doing with Genesis and how the Coast Guard's engagement is. Do you realize the next go live for MHS Genesis is actually going to be from Homeland Security? It's going to be Coast Guard. So we've got VA, we've got DoD. We're going to have 3 departments using the Genesis capabilities coming very soon. So it's very exciting what we're able to accomplish in a joint perspective. And then what we did in the JHIE, or the Joint Health Information Exchange, is kind of foundational and changes what we're doing and how we approach it and the joint approach to it. But we have room to go there, right? We're doing the pre-fetch. So based on the appointments, we go out and we find all the community healthcare provider information, and it's sitting there for the physician or the providers when they come in the morning. So it saves them time. They can look at it immediately. And then as we go forward, we're looking at Commonwealth and tying in tens of thousands of additional healthcare facilities and providers and the information that they can provide. So it's really been very beneficial to bring in with or without COVID. And then if you get strictly into the COVID, another thing we were able to do in support specifically of the Mercy and the Comfort was to bring in a technology that actually gave folks that were working in those environments direct access to community provider information. And that was sort of a shortcut around what we're doing with the JHIE, but it's a subscription service that we were able to get in place and really support that process as well.
Well, perfect. And as a quick transition to that, with the transition from some of the data management from PATS J6 over to DIMS, why is data sharing and data management so important in the digital transformation of IT systems?
Well, it's not even about the digital transformation or the transformation of IT systems. What are we trying to do in the health IT space? We're trying to get the right data about the right patient in front of the right provider at the right time, and then simplify capturing new data about that patient and allowing the sharing of that to other encounters and other providers. Now, Pat's vision, as I understood it, and I thought it was a brilliant move on his part, was that as we go forward into the future health IT and military health system IT capabilities, the capabilities we're using to support that system, the center is sharing the data and capturing data. And the core of that is what is accomplished in what is the military health system information platform. So that data platform and what we're doing, bringing in the new Healthy Intent platform, tying that together and using that as the core of our capability delivery across the military health system and across the joint federal health system, right? With the VA and the Coast Guard and whoever else joins the federal health system that we're creating here. It gives you that opportunity. So an example, we have treated in the past MHS Genesis is sort of the MTF solution, and then JOMIS, our operational medicine solution, as something separate, maybe that went to CENTCOM or it was a COCOM support, deployed forces support sort of model that we envisioned. As we're going through the COVID response, what we recognized and really what the professionals at DHA recognized and told me we needed to accomplish was getting things like medical situational awareness available at the MTFs and at the bases. And an example that was given to me is, why are we making people go to the clinic to get to these tests? Why don't we put a backpack full of test kits on a medic and send them to the unit, and they can do the collection at the unit? It's less disruptive to the unit. We're getting training for that that medic while they're not deployed. So we're hitting medically ready force, we're hitting ready medical force, and we're tying what we used to consider operational medicine capabilities to the CONUS and the base operations. And so the key to that is the data sharing and sharing that data out from the core MHS Genesis capability to these individual capabilities that we deploy. And so good move, Pat. Thank you.
Yep. So I'll tell you, it's the problem. It's the reason we're building Genesis. So I'm the legacy guy, right? I've got 100 plus instances of the outpatient EHR and 52, I think, of the inpatient EHR, and then a dozen other systems that sit on top of it that try to create the illusion of consistency, whereas Genesis is, one thing. And so it's really the cancer. It is the problem. And I have to chuckle when I see Mr. Tinston get asked questions like, how are you dealing with the challenges of the new EHR? And I'm like, challenges? The challenges are with the legacy system. The new EHR is the answer. And so I think we're doing the right things. Over.
Well, so I'd like to close with one more question. Just real quick in a brief summary. Bill, I'm going to ask you first, and then Pat, I'll follow up on your side. But in the current pandemic, how has that really affected our EHR efforts between DoD and VA? Bill? Well,
so the most obvious thing we've already talked about, so I won't spend a whole lot of time on it. But the most obvious thing is it has created an awareness of the immediate need to get virtual healthcare capabilities, to extend the access to care through those technologies, which VA was already exercising and executing. But on the DoD side, we needed to get that done. And so we're taking those actions. But the other thing it's done is we're facing the same situations, right? On the MHS Genesis side, we did not stop the MHS Genesis program, but we did suspend our engagement with providers because they had a mission that was more important than getting the EHR deployed, and that was supporting the nation and the military health system in the pandemic response. So we've been disengaged from them. The VA has had the same experience. So we have had the opportunity to look at how we deliver capability to first, because we have deployed sites, how we effectively support the needs of those deployed sites in Wave Travis and our initial sites with their needs in COVID-19. And we have found that we can be very responsive in the modern centrally delivered capability that we're doing in MHS Genesis. We've been very responsive to those sites. But how do we, as federal healthcare providers, VA and DoD, deliver more capability more quickly and be more responsive? And we have spent the time looking at how to do that together, which is different. It's different than what I experienced a year ago, and I think you would hear the same thing from John Wyndham, what he was experiencing a year ago. We don't have these conversations without Mr. Wyndham, Dr. Evans, and myself in the room, and I think you're going to see some amazing things from us as our ability to engage with the MTFs opens up. And I think we're going to have some surprising outcomes and schedules that you see, because we've been doing a lot of hard work about how to bring innovation to how we deliver, not just to the capabilities that we deliver, but in how we get this stuff out and how we behave as acquisition professionals.
Perfect. And Pat, to close out our little panel, since you had brought up the tribulations with legacy systems, and you and I have talked at length over about the legacy systems for the several years now, what about the impact of the pandemic on our legacy system sustainment and given the MedCoy push?
There really wasn't a problem with that, other than, the virus brought the need to hook a lot of new testing equipment up, right? And so if you want to hook the testing equipment up to the outpatient EHR where the testing was being done, well, that's over 100 systems, right? So that's a ton of work. In Genesis, since, oh, by the way, we had to do it with both Genesis and the legacy systems. And with Genesis, it was pretty simple because you only had to do it one time. With CHCS, we still struggle in places where we don't have them all hooked up. You can still use them, but then getting the results in, you have to key it in. And the reason that's bad is they're only keying in the positive ones to make sure it gets put in a person's record. Well, for statistical analysis and other things, we want to know the negatives too. And so we've chipped away with that since the pandemic started. So that was one thing. And then, with respect to sharing of data, we didn't, first of all, there was no problem. There was no huge problem sharing with the VA. There was, however, an issue sharing across the federal government. And the reason was DoD data has some special concerns, right? Like OPSEC, so who's sick where, on what ship, in what place. And so there's a lot of concern about putting that kind of information with other information. And so, if you want level of the patient, we're really careful about that. If you want trending and things like that, okay, we made that work. Within the DoD, not really a problem. And mostly because in our Frankenstein of distributed layered legacy systems, we had the foresight many years ago to consolidate all our data into the MHS information platform, MIP, run by Chris Nichols, which now belongs to Mr. Tinston.
Well, perfect. Thank you very much, Pat, Bill. On behalf of GovCIO and everyone that was dialed in to listen, thank you for taking the time out of your morning. That will conclude the panel session. And Mike, I'm going to turn it back over to you.
All right. Thank you so much, gentlemen. That was fantastic and really informative. So I'd like to close by thanking all of our speakers for joining us today and sharing their experiences navigating the major shifts caused by COVID-19. We've heard about the move to mass telework, enacting the VA's fourth mission, telehealth, and much more about data sharing. We'll continue to follow this important topic on our site. Follow our coverage for updates to these platforms or to these conversations on our platform at governmentciomedia.com. And please be sure to subscribe to our series of podcasts where we will also be covering data sharing in this age of COVID. I'd like to thank our sponsors, first and foremost, LexisNexis Risk Solutions, as well as Dell Technologies and Slack for their partnership on this event. We're grateful for their continued support. I'd also like to encourage everyone on here to sign up for our next virtual event called Digital Services to Respond to COVID-19. We'll be hosting that next Wednesday, June 10th at 1 p.m. Eastern. We're excited that we had well over 600 folks sign up for this morning's event, and we're hoping you'd like to continue to join our community and watch our series of future virtual events. We'll dive into more topics surrounding the government's digital response to this pandemic. Again, thank you to our speakers, sponsors, and everyone who tuned in this morning. We're looking forward to hosting you again. Thank you.